I think this is going to be a very important question. Nivolumab, ipilimumab, hands down, beat the TKI sunitinib with an overall survival benefit. But there are many considerations. First and foremost is the toxicities and how practitioners are going to be familiar with managing immune-related adverse event. Second, the regimen has shown the activity mostly in intermediate and poor risk. Actually, if you look at the small group of patients with good risk disease, responses and progression-free survival seem to favor sunitinib. Third and most important, something we tend to forget about, is that immuno-oncology drugs now are giving intravenous, while the TKI are oral. So there could be, there is a patient preference here, between visiting the hospital and not visiting, the hospital as frequently for the infusion. So it's actually an evolving story too. What I think is going to happen, rather than a TKI versus, an IO, there'll be, the next few years, several combination TKI plus IO that we need to figure out how to use them. Because fortunately or not fortunately, all these combinations from phase 3 well-powered trial were compared against sunitinib and are not compared against each other. So I think this is again an evolving story, and hopefully I'll be here the next few years to discuss these results. So the combination of bevacizumab and interferon showed activity in the frontline setting in some time ago versus interferon, which we don't use now. I mean, that combination doesn't have any advantage currently over what we use in frontline study, and we do not actually use it much. Now, temsirolimus is a drug that showed activity again against cytokine in patients with poor risk renal cell cancer. I think the schedule of temsirolimus intravenous weekly, and the fact that overall in an indirect comparison, mTOR inhibitors usually have not fared as well as VEGF TKI, dampen our enthusiasm for using temsirolimus.